just gonna pull my mask. Okay, good morning. My name is Stephanie. I'm a PGY3, and I'm going to be talking about traumatic dental injuries. So special thanks to the Procedure Day faculty and resident coordinators, Dr. Camacho, Gennaro, Dr. Kwok, Kadakia Desai, Roboyo, Dr. Wolfram Stetson Park for coordinating Procedure Day and help with my lecture. So first, we're just going to go over the anatomy of the teeth, differences between adult and pediatric dentition. This is important, mostly just for pediatric dentition versus adult dentition and distinguishing primary versus permanent teeth. This will change your management when we talk about dental trauma. Additionally, we'll need to have some familiarity with the numbering and naming system of teeth when assessing for injuries, especially in the cases of avulsions and trauma. We'll need to account for all of the missing teeth. And then after that, we're going to go over general approach to any patient who presents with dental trauma. And then finally, we'll go over management of specific dental injuries, subluxation and luxations, tooth avulsions, and dental fractures. So dental trauma accounts for 5% of all bodily injury, but up to 17% in preschool children. Dental injuries in younger patients are often due to falls or accidents. In older patients, again due to falls, but then also consider assaults and MVAs. Dental trauma presenting to the ED tends to involve the permanent dentition, and most commonly the anterior teeth. Specifically, it tends to involve the maxillary central incisors, the maxillary lateral incisors, and the mandibular incisors, which I'll point out later. And dental alveolar injuries also tend to be found in association with other fractures, specifically fractures of the mandible and the face. So those are things to take into consideration when patients come in with dental injuries. So just a little bit about dental anatomy. You need to be able to account for all of the patient's teeth. So this is where we have to have some familiarity with the numbering and classification of the teeth, as well as distinguishing between primary and permanent teeth for pediatric patients. So in terms of tooth development, the emergence of the teeth from the gingival margin or the gum is referred to as tooth eruption. So there are two stages of tooth eruption, primary and secondary. There are typically 20 primary teeth and 32 permanent teeth. So the first primary teeth, which you see in the middle image, these erupt typically at around 6 to 10 months of age, and it's completed by about 3 years of age. The primary teeth are identified using a system of letters A through T, or they can be identified using anatomical locations. So this is like molars, incisors, canines, probably the system that most of us use. For permanent teeth, this can be classified using a numbering system from 1 through 32, and 1 starting in the upper left third molar, and then going to the upper right third molar, to the upper left third molar, number 16, and then going down to the lower left third molar, number 17, to the lower right third molar, number 32. Again, it's often easier though to describe the teeth using the anatomical location. So you have 3 molars in the back, followed by your premolars, your canine, and your incisor, and you would then describe that as your left lower incisor or your right lower incisor. You can use whichever system you like. The most important thing is that you accurately identify, assess, and document whichever tooth it is that is affected or injured or avulsed. Simply saying there's like a broken middle upper tooth that's bleeding is usually not sufficient. In terms of primary teeth versus permanent teeth, children begin to lose their primary teeth through a process called exfoliation. This begins at around age 6. So as the permanent teeth push towards the gingival margin, the root of the primary tooth is resorbed into the alveolar bone, and this causes the primary tooth to fall out. So some of the ways that you can differentiate between the primary tooth and the permanent tooth is by their appearance. So primary tooth in children tend to be small, very white. The crown will be bulbous looking, and it'll be very worn with sort of flat edges, whereas permanent tooth will look larger and creamier in color, and it will have jagged edges. And again, you can expect that the permanent teeth will appear sometime around age like 6 to 8. And this is important because with avulsion specifically, primary teeth should not be reimplanted in children. Reimplantation there is a potential for injury to the developing tooth bud, and specifically there's a potential for ankylosis, which is causing fusion of a tooth to the bone. So if a child comes in with avulsion of their primary tooth, you should not reimplant, and you should have the child follow up with their dentist in 1 to 2 weeks. Permanent tooth avulsion, on the other hand, should be reimplanted, and this is where time is tooth, and I'll touch on that later, but that should be reimplanted in a timely manner. Just a little bit about tooth anatomy, because this will matter for assessing fractures. But the top of the tooth that's exposed is referred to as this is the visible portion above the gum. This is the crown, and then the root extends into the alveolar bone. You sort of have 4 layers of the tooth. You have the enamel, and then this is the hardest part. You can see that the surface is the hardest part and the most mineralized substance in the body. It covers and protects the crown of the tooth. It's the only part of the tooth that's not able to regenerate. Then you have the cementum, which you can see sort of right here. I don't know if my mouse is wrong. Okay, it's here. You see the cementum right here. So the cementum is the substance that covers the root of the tooth. It's a very thin layer compared to the enamel. The periodontal ligaments are fibers that project from the cementum and attach the tooth to the surrounding bone. And the periodontal ligaments are important. Those are the ligaments that you're trying to preserve in a tooth avulsion. Then the next layer is the dentin. So this is this sort of yellow spongy layer right here. The dentin is the internal layer that sits beneath both the enamel and the cementum. The dentin can regenerate from the pulp. However, its ability to regenerate really depends on the overall health of the tooth. It's less likely to regenerate in the setting of trauma, or if a patient has sort of dental caries and poor dentition at baseline. And then finally, you have the pulp, which is the innermost layer. So the pulp is the core of the tooth. It is the regenerative center, and it holds the neurovascular supply of the tooth. Okay. So just a general approach to any patient presenting with dental trauma, your first step is always to assess their ABCs. Is the airway intact? Are they breathing comfortably and spontaneously? That's a hard stop. And next, you want to assess if they are at any risk for aspiration. Do they have any loose or damaged teeth, or have they possibly already aspirated any teeth? After this, you want to assess their circulation, and this is providing any hemorrhage control. Usually this can be done with gauze and direct pressure. You can even just have the patient bite down on gauze to achieve hemostasis. Ideally, for all of your dental patients, you really should have suction set up. This will help for visualization of any injuries, and also to stabilize like a potentially bloody airway. Once the ABCs are addressed, you want to take a brief history of the trauma. For tooth avulsions, especially, it's important to find out when the trauma occurred. As I mentioned, time is of the essence. The longer that the tooth is out, there's a greater chance of loss of viability of the tooth. Then you want to take a full history of what happened, consider like the mechanism of the injury. Is it a fall, a fight, assault, and MVA? In children, consider child abuse. In adults, possibly consider domestic abuse. And then always ask about any associated injuries. Traumas don't happen in isolation, and while the facial trauma or the dental trauma might be the most striking thing, you want to come back and really assess them for any additional injuries. And then ask about previous dental history. Do they have any crowns or prosthesis already? Next, you want to examine the patient. So that starts with sort of inspection. And so this is seeing if they you need to be able to ID all of the teeth and see if they have any missing teeth or any fragments that have been recovered. So this is examining the chest and especially the soft tissues of the mouth, making sure they don't have any teeth lodged anywhere or any lacerations to the oral mucosa or the gingiva. This is also where imaging may come into play. Adults can usually tell you if they've lost any teeth or can find the teeth, but kids may not be able to tell you if they've aspirated or swallowed any teeth. So you may need to obtain imaging to locate any lost teeth. Next, palpate. Palpation is very important. You need to be able to identify if there are any loose teeth or any teeth that are painful to palpation. Again, loose teeth are aspiration risk. And you also need to identify if there are any step-offs, any mandibular or maxillary bone tenderness, because these may identify underlying fractures. And then finally, do a functional assessment, any disturbances or changes in the bite, check for symmetry of the mouth or any malocclusion. Imperfect positioning of the teeth when you ask the patient to bite down can indicate an underlying fracture. And then this I'll talk about later, but once you sort of do the workup for the patient, discharge planning will be important. Almost all patients who come in with dental trauma will need outpatient dental follow-up. So it's important, and some of them may need antibiotics on discharge. So it's important that we ensure good follow-up for all these patients. So the first injury we're going to talk about is subluxation. So subluxation is when the tooth is mobile but not displaced from the socket. So teeth that are minimally mobile and are not displaced actually do very well with just conservative treatment. The tooth will tighten up in the socket as long as it's not re-traumatized. So this patient should be instructed, so once you do a good examination and make sure that it's not displaced, this patient should be instructed to eat a soft diet for 1 to 2 weeks, and then they can follow up with their dentist as soon as possible. And it doesn't really require any additional stabilization or discharge really with any antibiotics. Luxation, on the other hand, refers to a tooth that's partially displaced from the socket. And this type of injury can involve disruption of the periodontal ligaments and may involve underlying injury to the alveolar bone. In this case, if it's an injury to a primary tooth in a pediatric patient, you can leave the tooth alone and let it erupt, or you can slightly reposition the tooth. If a permanent tooth is in the wrong place, as it is in this patient has 2 injuries. They have both an incisor fraction and a luxation of the upper right central incisor. The teeth should be repositioned and splinted, which I'll talk about in a second. And then this patient, once you splint this tooth back in the correct position, this patient can be discharged with a 24-hour dental follow-up, and they should also be placed on a soft diet so as not to re-traumatize the tooth. For avulsed teeth, this is where time is of the essence for permanent teeth. So avulsion refers to loss of the entire tooth from the tooth socket. This is a true dental emergency. Again, the anterior teeth are the most commonly involved. So reinsertion is best done within a few hours. So the first thing you want to do is you want to clean the tooth with normal saline, and you want to clean it gently. Don't ever scrub the tooth. It should just be gently cleansed with normal saline. And then you want to place it in a storage medium. The storage medium is actually more important than the time out of the mouth. In terms of which storage solution works best, if you have access to like a balanced sodium solution, ones that I saw in the reading is like Hank's balanced sodium solution. These are basically like it's a solution made to like a physiologic pH, and it has an isotonic salt concentration. They're also available commercially. It's called like Save-A-Tooth. Those work really well. If you don't have access to that in your ED, you can also use like an oral rehydration solution. Those work the best, but if you don't have that, you can use milk. You want to clean it and then place it in the storage solution immediately. That's your first step. If you don't have that, the next best thing would be saliva, and then if you don't have that, then you would use saline. I think the easiest thing is probably milk. We almost always have milk around the ED, and then if you can place the milk in like a bucket of ice, or place an ice pack around the milk just to keep it cold. Always try to manipulate the tooth by the crown. Don't touch the root of the tooth because you don't want to disrupt the periodontal ligaments on the tooth. In terms of like what works best for the storage solution, it does affect the cell viability. So if you store the tooth in just like a dry bag with no medium at all, the cell viability, the viability of the tooth is less than 60 minutes. Storage in milk gives you about 3 to 8 hours. If you can get one of these like if you get an oral rehydration solution or a balanced sodium solution, you can get viability up anywhere from 12 to 24 hours. So it's really key to sort of do that. Next, you want to sort of attend to the patient at this point. So you want to clean the area, suction the tooth socket, and irrigate it, and then administer a local anesthetic. A dental block is great, kind of what Nivi just talked about. You want to administer a local anesthetic and then work on reinserting the tooth. And you want to make sure the tooth is inserted correctly. One of the ways you can ensure that it's in a good place is by having the patient bite down. If they have a good like symmetric bite, you can that's pretty good reassurance that the tooth is in place properly. And then I'll talk about in a second how you secure it. But then once that's secured, the patient should see a dentist within 24 hours and be discharged with antibiotics and tetanus. So this is actually the splinting application that you would use to secure the teeth. You can use it for both avulsed teeth as well as luxed teeth. This is the Copac application. I don't think we actually have this at County, but I think we do have it at Downstate. But Copac is like, it's a periodontal paste. It's supplied as both a catalyst and a paste. So you place the catalyst and the paste separately, and then you mix it together. And then you put the paste on your gloves. You should use a lubricant on your gloves before picking it up, or else it'll just stick to your gloves. And you roll this sort of clay-like mixture between your fingers. And then you have to make sure that the teeth are dry. So you dry the teeth with a gauze. If the teeth are wet, it won't actually stick to the teeth. So you dry the teeth with the gauze, make sure you lubricate your gloves, and then you want to press the Copac into the grooves of the teeth, and then apply it both to the front of the teeth, into the grooves of the teeth, and the back of the teeth. And again, ensure that they have a good bite and that it's stable, and allow it to dry. Discharge the patient home with a soft diet and 24-hour dental follow-up. So it's pretty simple to use if you have it. If you don't have it, an alternative that I found that I thought was pretty cool is you can use a Dermabond and a bridge of an N95 mask. I hope you can see the picture, but you can use this for dental avulsions and also for to stabilize luxations. It's a temporizing fix, but you do all of the same things with cleaning the tooth and making sure it's in a satisfactory position. Again, the tooth needs to be dry for Dermabond to work well, but what you're going to do is you're going to apply Dermabond to the edges of the dry tooth, place the tooth in position, make sure it's in a good position, and before you actually even do this, you're going to obtain the metal piece of the bridge of a N95 mask that you can see here. You're going to measure it to make sure that it's a good size to act as a splint. You may need to cut it and file it down to make sure that there are no sharp edges, and make sure that it fits properly. And then you Dermabond each side of the tooth, secure it into place, and then you apply Dermabond to the back edge of the N95, and then use it as a splint to the teeth. Again, making sure that it's dry. And you hold the splint under pressure for about 1 minute and make sure that the tooth is stable, and then you can give them 24-hour follow-up. So I thought this was a cool alternative if you don't have a Copac kit. The next injury I just want to talk about is dental intrusion. So this is apical displacement of the tooth into the socket and into the alveolar bone. It causes disruption of the attachment apparatus, and it is often accompanied by fracture of the alveolar bone. A clue to this is that the tooth can appear shortened or missing altogether. So this can be on the differential. You may think that the tooth is avulsed, but actually there's an intrusion. The management for this depends on the degree of intrusion. If the intrusion is less than 3 millimeters, this can be left alone to erupt spontaneously, but the patient needs to have dental follow-up. For deeper intrusions over 3 millimeters, the tooth really should be repositioned and stabilized. Although this can be completed at a dental follow-up. Intruded teeth are immobile, so they don't necessarily require stabilization in the ED because they're not necessarily like a aspiration risk, but they can have really bad outcomes. They're at risk of pulp necrosis, infection, deformity. So you need to be able to recognize it and identify it. If you don't see it, you may require additional imaging like a CT scan to recognize that it's intruded, because they need to be referred to dental. And then lastly, just gonna briefly touch on dental fractures and how we manage those in the ED. Starts by determining the extent of the fracture, and then tooth salvageability. The classification system that I'm gonna talk about is Ellis classification. Basically, there are 3 types of fractures. There's an Ellis class 1 fracture. So this is a fracture through the enamel. It's the most common type of fracture. The tooth is not very sensitive in this type of fracture. And no emergent intervention is really required, but you should refer them to a dentist. And pulp necrosis is rare in this instance. It's about 0 to 3%. One thing that you should do is you should smooth any sharp edges of the tooth to prevent injury, or if they're having pain from it, and you can just use an emery board to do this and give them sort of routine dental follow-up. Type 2 Ellis dental fracture is a fracture through the enamel and the dentin. This will have a yellow pinkish appearance. The dentin is visible sort of as a softer, like golden yellow middle layer. This can be exquisitely sensitive to temperature. This is at risk of pulpal contamination. If you have greater than 2 millimeters of dentin, then this may be protective against a pulpal necrosis. Early intervention is required to prevent contamination of the pulp if you have dentin involved. And in an LS2 fracture, this does need intervention in the ED. Specifically, this fracture needs to be covered with the sealant of calcium hydroxide. And in this instance, a dental block works very well because the patient will have a lot of pain with this injury. Pulp necrosis is higher, about 1 to 7%. I mentioned again, you would cover this with calcium hydroxide, and you would discharge this patient with a soft food diet and dentist follow-up really within about 24 hours. And then finally, the Ellis class 3, as expected, it's a little bit of a deeper dental fracture. This really involves all 3 layers, the enamel, the dentin, and the pulp. This is very painful, although if they have desensitization, if there's neurovascular disruption, they may not have pain. You may expect to see some bleeding with this fracture, but if the neurovascular bundle is involved, you should always evaluate for pulp exposure. There's considerable risk for abscess formation with this fracture. You should again cover the exposed pulp with calcium hydroxide. You should warn the patient that they may need a root canal for this type of fracture. Pulp necrosis is pretty high, 10 to 30%. They'll have severe pain. They'll be temperature sensitive. This is a dental emergency. You should really call the on-call dentist for this. They should be seen within 24 hours, and this patient should be discharged with antibiotics. The major point, if the fracture involves any dentin or pulp being exposed, they need a protective sealant of calcium hydroxide to reduce pain. I'm sorry, not to reduce pain, to protect the tooth. And this is just what the calcium hydroxide sort of looks like. It looks very similar to the previous one, but basically it comes as a catalyst and a base that you mix together, and then you just apply it to the fractured tooth. And then lastly, just quickly going to cover alveolar fractures. The alveolar ridge fracture, it's a fracture of the alveolus, or the tooth sort of bearing portion of the maxilla or the mandible. This can involve a single tooth, but often it occurs in multi-tooth segments. It can vary in the number of teeth involved, the amount of displacement, and the amount of mobility of the affected segment. Fractures tend to occur most often in the maxilla, which is thinner, and the anterior alveolar process is at greatest risk for fracture because it tends to be a more exposed part during trauma. You can have both subluxations and avulsions of the teeth that are associated with these types of fractures, and you'll see that the teeth will often look very like misaligned and mobile, and multiple parts of the multiple teeth will be involved. Imaging, in terms of management in the ED, really our goals are to preserve the avulsed and avulsed teeth and viable tissue. You want to start with gentle direct pressure of the alveolar segment with a saline soaked gauze to try to preserve any of the avulsed teeth. Unlike fixation for like just normal single avulsed teeth, fixation for alveolar fractures should be rigid in order to allow proper bone healing. So this is like an oral surgery consult that requires wire stabilization or an arch bar fixation. This is not like a simple fixation thing. This really requires a rigid stabilization. The urgency of it depends really on the mobility and the extent of the displacement. This is like a very large mobile segment that is a very high aspiration risk, I would say, and this should be fixed immediately. If it's a small stable segment, I guess it could ideally be repaired in like 24 to 48 hours. But I think most of these should be wired and repaired pretty immediately. These patients should have their tetanus updated, and then they should also receive antibiotics covering like oral flora. Some good options would be like penicillin or cephalosporin or clindamycin. In terms of outcomes for these patients, they can have a lot of like cosmetic deformities because they can lose a lot of the bone. They can lose a lot of the bone. So we really need to work on preserving like any viable tissue that they have and making sure that they have a good follow-up. And just something to remember, alveolar ridge fractures can also happen in edentulous patients. So any patients with dental trauma, if they come in and they don't have teeth, it's still important to assess them for having possible fractures. So just some basic take-home points. Always perform a thorough oral exam to identify dental emergencies, especially like examine all the teeth to prevent possible aspiration risks. Remember to look for concomitant injuries in patients who have dental injuries. Look for concomitant mandible fractures or maxillar fractures or other facial fractures. Dental emergencies are avulsions, time is of the essence, intrusions, and Ellis class 3 fractures. More urgent conditions are the Ellis 1 and 2 fractures, luxations, and subluxations. Always ensure that the patient has a pain airway. And hemorrhage control, you can simply do this by having the patient bite on a gauze. In terms of ensuring that for dental avulsions, you can assure that you have good placement by having the patient bite down and have good occlusion. And then for good post-discharge instructions, you want to warn the patient of some post-dental trauma risks, including tooth resorption, discoloration, potential tooth loss, and or the need for future root canal. And then finally, almost all of these patients need good dental follow-up. Access to dental care, especially urgent dental care, is often limited for many people. So we just really need to make sure that patients have a good and timely follow-up for dental traumas. And then these are my references. That's it. Any questions?
I think you did a really comprehensive job. Yeah, the big things I think you forget a lot of times is checking for loose teeth for aspiration risks. And I think the Ellis classification we use a lot, but dental doesn't.
Yeah. Yeah.
How do you really tell between luxation and subluxation? Like one is specific, so the other is.
Yeah, it's displaced. I honestly think you have to kind of like pull on the tooth and see if you can actually remove it from the socket. Yeah, like you got to get in there and see if you can actually displace it from the socket. Yeah, and that's how you would know. One is freely mobile and one is not. Yeah.
I think it's a great talk. I listened in the car.
Oh, you did?
But you know, this is not something we do a lot.
Yeah.
But you work someplace, you're not going to have a dentist on hand in the hospital 24/7. We're kind of spoiled in that way. So if you're going to go work someplace, you might actually have to do this. You might have to split the tooth or lend the tooth. So it's really important. And a lot of places will have to do it.
Yeah. And I don't know if we, Kings County run a dental box, council used to have a dental box. I don't know.
They still have them.
Yeah, Naomi told me yeah.
It's in the
Station.
Yeah, Naomi told me she had it the other day, so yeah.
But it could be an easy QI project or something.
Yeah.
Just get our dental box.
It's really not ever going to be something you transfer a patient to. Urgent follow-up is going to be tomorrow morning. I mean, that would be maybe a severe trauma, like airway issue, so that you might admit that patient in a trauma situation or trauma. But I mean, like LS3, you need emergent evaluation. They're not going to come in the middle of that.
Sorry,
You cover that and you.
what was your question? Oh, Wesley's asking for alveolar ridge fracture. Would you transfer? Yeah, no. Yeah, they would have follow up with the dentist. You try to stabilize it as much as possible. Yeah.
Isolated dental trauma.
Mm-hmm. You don't transfer those. Yeah. I think we have such good access to OMFS that we don't ever have to do that. Yeah. Okay. Thank you.